We're going to be talking about cardio-renal and hepato-renal syndromes, and at a first pass, this seems like a large subject to fit into a relatively short period of time of the 40 minutes that we have. But in actuality, there's a lot that's similar between the two groups of disease processes and natural histories, and I certainly think this is the reason that the conference organizers grouped them together in this discussion. And I hope to align our thinking as we go through the process of discussing. There will be two cases and then some of the clinically important factors associated with each. So I just have to disclose that I'm a medical director of a for-profit dialysis company. We're going to start off by talking about the cardio-renal syndromes. And the outline will be a case presentation and then classification, pathophysiology, and some of the treatment strategies that are available to us. And so we'll start with a case which I'm sure is very familiar to all of you. This is a typical case of a 75-year-old man with cardiovascular disease from prior admissions with congestive cardiac failure and acute kidney injury. And he presented to the emergency department with a weight gain of 15 kilograms. He was somnolent. There were clinical findings of volume overload and a BUN of 150 with a creatinine of 3.8 milligrams %, and there'd been a recent titration of his diuretics in the primary care setting. He had a previous history of morbid BMI, insulin-dependent diabetes, hypertension. He had chronic pain syndrome, a history of staphylococcal infection, and at the time that this had occurred, approximately a year before this presentation, he'd undergone a renal biopsy which showed an acute IgA glomerulonephritis, which was treated and felt to be in remission and was felt to be a staphylococcal-associated IgA. His medications were torsemide, 80 milligrams twice a day, metolazone, 2.5 milligrams a day, recently up-titrated. He was on lisinopril, Lantus insulin, and oxycodone. On examination, he was mildly hypertensive at 150/80 with a heart rate of 96. He was lethargic and somnolent. There were distant cardiac sounds with an irregular rate and rhythm. His JVP was prominent, bilateral rales greater than halfway up on posterior lung fields, truncal obesity, lower extremity edema with venous stasis changes, all clear findings of acute on chronic heart failure. His laboratory data was notable for a serum sodium, which was decreased at 128, potassium of 3.2, bicarbonate level of 36 with a chloride of 84, CBC, white cell count of 14,000, hematocrit of 44, platelets of 250,000. His troponin was not elevated at 0.02 with a BNP of 20,000 and a chest x-ray with pulmonary interstitial edema without pulmonary infiltrates. So we've all seen this kind of case before, and we're faced with treatment options. And fundamentally, as the nephrologists, this will be our focus as to how to optimize his volume status, prevent him from developing worsening acute renal failure while we do it, and get him out of heart failure. So certainly our treatment strategies are going to involve some form of volume control with diuretics, either IV Lasix as an intermittent bolus, IV Bumex as a continuous drip, together with oral metolazone twice a day. We could use intermittent dialysis initiation as an option. We could start the patient on continuous venous hemofiltration, or we could start him on a Lasix drip and use oral metolazone. And those are kind of the 5 choices that we have as we approach this patient. And we'll give the answer at the end of the talk, but hopefully that'll be able to focus your minds as to maybe what you would be doing at this stage, and then you could see at the end of the talk when I told you what we actually did if our thinking processes were congruent. So in about 2004, the National Heart, Lung, and Blood Institute decided that it would be important to classify this group of illnesses which follow a common natural history, the cardio-renal syndrome classification, for patients who present in a similar fashion to the one described. And so cardio-renal syndrome was categorized into 5 groups, and they are listed here: the acute cardio-renal type 1, chronic cardio-renal type 2, acute renocardiac type 3, chronic renocardiac type 4, and then secondary cardio-renal syndrome. And their definitions are as listed: acute worsening of heart function leading to kidney injury or dysfunction. Those are sort of the patients who show up in the emergency room with these rather dramatic findings that we were alluding to. There are the folks who present with a more chronic course with chronic congestive heart failure leading to kidney injury and kidney dysfunction in that setting, the kind of chronic heart failure milieu. Acute worsening of kidney function leading to heart injury and or dysfunction. These are folks who present potentially with the RPGN type of picture. And then the chronic kidney disease leading to heart injury, disease, and or dysfunction, the type 4, that kind of categorizes that vast population of patients that suffer from myocardial disease as a result of chronic kidney disease. And then the last category are systemic conditions in which cardiac and kidney failure occur. These are folks who present with sepsis, potentially, for instance, folks who have severe influenza would be an example. Are there kind of predictors of what patients are going to fall into this population? Well, there are, according to the published data. This is not rocket science. Age plays a role. Whether the patients have chronic hypotension as a result of their heart disease will certainly place them in a higher risk category for ending up with the cardio-renal syndromes. Anemia, diabetes, hypertension, obviously the systemic illnesses that play a role, combination of loop diuretics and thiazide. The severe diastolic heart failure group, these are folks who usually have a hypertensive or ischemic background. They're certainly going to be at risk. I find that this category here with secondary pulmonary hypertension are a particularly difficult group to treat and often end up with pre-renal renal failure. Those with right ventricular function, bad mitral and tricuspid valve disease clearly are issues that play a role. And then no-brainer if they've had previous heart failure, hospitalizations indicating a worsening natural history of their cardiac disease. On the renal side, certainly baseline renal function plays a role, hyponatremia, history of acute kidney injury from previous decompensations, and history of ultrafiltration or transient dialysis are kind of going to place us into that cardio-renal milieu. These graphics are often difficult to follow, particularly late in the afternoon on a screen that's far away from you, but fundamentally it just shows the tie-in between the physiology, both at the neurohumoral level and at organ level, of how progressive cardiac function and progressive renal dysfunction are tied together. Progressive heart failure leads to increased sympathetic nerve activity and then downstream pathways, which will ultimately affect renal blood flow and impact on GFR. There's activation of the renin-angiotensin system, which is very central to all of these processes, increasing afterload, decreasing contractility, and increasing volume, which will all impact on the cardiac side. And then clearly also decreasing cardiac output, which then impacts on the kidney side in terms of renal blood flow, congestion leading to increased renal efferent arteriolar pressure, and ultimately there are oxidative stresses, components from anemia, which have impacts at the cellular level, and in their most extreme form resulting in apoptosis and fibrosis, both in the kidney, but should also point out that some of these cellular processes occur in the myocardium as well, particularly in the chronic disease categories. Whoops. So I think one of the important parts of this presentation in terms of the physiology is the concept of venous congestion, which we kind of tend to overlook, because in my mind for many years the thought was patients who present with concomitant cardiac and renal failure are as a result of heart failure leading to disturbances in cardiac physiology, the heart operating in unfavorable parts of the Frank-Starling curve, decreased cardiac output and decreased renal perfusion on that basis. And that certainly plays a role in some patients with cardio-renal failure. But in actuality, in a large percentage of patients, cardiac output is indeed preserved. And one of the key elements that is felt to be playing a role is the concept of venous congestion, the congestive part of congestive cardiac failure. And multiple studies have demonstrated this link between elevated venous pressures and decreased renal function. And we have some graphics on the left-hand side of the slide here to illustrate it. But the net of it is that the kidney is an encapsulated organ, and it's functionally susceptible to increased venous pressures. And the net result of congestion and increased venous pressure is that we are impacting on physiology at the glomerular level, which results in decreased GFR. And the venous congestion can also cause higher intraglomerular interstitial pressures, which will then ultimately impact on tubular functional processes. And this exacerbates the renal failure component. And this certainly is a key component, particularly in the acute and the cardiac-generated parts of the cardiorenal syndrome. Those are the types 1 and type 2. One of the issues about management comes if we sort of look at these concepts of cardiac output and venous congestion. Would our management be improved if we knew what the numbers were in terms of monitoring central venous monitoring, placing Swan-Ganz catheters in these patients, and then titrating therapy in order to improve outcomes? And that sounds intuitive and the right thing to do, but as it turns out, and this is data which came from a review of the ESCAPE trial, which is a large multi-center trial looking at cardiac failure outcomes, and it stratified patients according to their admission glomerular filtration rate and levels of renal insufficiency, and a pulmonary artery wedge pressure was obtained, and then treatment was titrated. And what it found is that essentially in patients who received central venous monitoring versus those who didn't, there wasn't really any significant improvement in outcome. And therefore, as we approach management of these folks, central venous monitoring is felt not to be superior to overall clinical judgment in terms of our assessment. What should we be doing in terms of diuretic therapy? There have been sort of lots of studies, and the time constraints within the course of this talk don't allow me to include them all. But in summary, there are some pretty good recommendations which come from the American College of Cardiology, American Heart Association in terms of guidelines. And I think these are the principles that we should sort of all be practicing by, and that is that the goal of diuretics is to eliminate clinical evidence of fluid retention, such as an elevated JVP and edema, that the rate of diuresis can be reduced if there's hypotension or worsening renal function, and that the goal of diuretic therapy is to eliminate fluid retention, even if this leads to asymptomatic mild to moderate reductions in blood pressure and renal function. In other words, treat the congestion, treat the cardiac failure, use diuretics, continually evaluate how you're dosing your diuretics and the treatment response. And it doesn't make that much difference as to what your route of diuretics or how you shape your diuretic therapy, and I'll show that in subsequent slides. But before I get there, I just want to make a point about diuretic comparisons in terms of how we use diuretics, and I think this is information that is known to many of you, but it's worth emphasizing. That the three commonly used loop diuretics, furosemide, bumetanide, and torsemide, are listed here. The first two, furosemide and bumetanide, can be given either orally or intravenously. These are the typical dosage ranges. If you use sort of furosemide as the standard, 1 milligram of furosemide is equivalent to, 40 milligrams of furosemide is equivalent to 1 milligram of bumetanide, and 2 milligrams of furosemide equivalent to 1 milligram of torsemide. Torsemide has the greatest bioavailability in terms of its duration of action on the oral side. The duration of action of furosemide and bumetanide are approximately equivalent. One of the other pointers I want to make in terms of these dosage equivalents is, and I see this frequently in our hospital, and you folks should probably see the same in your hospitals and pay attention to it, is patients who get placed on bumetanide drip, it's fairly common to titrate the dose up to as high as 2 to 3 milligrams per hour, which would be equivalent to giving somebody 80 to 120 milligrams of Lasix per hour, which we would actually never do with a Lasix drip. So I generally have a restriction of 0.5 or occasionally 1 milligram on Bumex in terms of its hydration when we're giving it as a continuous infusion. With regard to the diuretic strategies, while we're talking about diuretics, this has been looked at and published in the New England Journal of Medicine a few years ago as to seeking guidance as to what is the best way to actually give diuretics to congestive cardiac failure patients who have a component of kidney failure. Should we use intermittent bolus dosing? Should we be using continuous dosing with a Lasix or Bumex drip? Or should we be using higher doses or lower doses in a stepped fashion? And the bottom line of this study and other studies is that there were not significant differences between the different types or mechanisms of diuretic delivery. It primarily relates to how the patients respond on a case basis, and that we can't globally say that if a patient has cardio-renal syndrome, a worsening renal failure, volume overload, that a Lasix drip or bumetanide drip is better than intermittent bolus dosing. And so it depends to some degree on physician styles as to how you like to practice. I personally do like the continuous drip formulation in that it allows me, I feel, a little bit more control over dose titration and response, and it has folks paying a little bit more attention to the I's and O's. But again, that's not based on literature, it's on a personal style. In terms of practices for removing fluid in patients who are suffering from cardio-renal syndrome, this concept of ultrafiltration is obviously an important consideration. And do we augment diuresis by ultrafiltering the patients extracorporeally to achieve our endpoints? This was a process which I think many of you probably remember 4 or 5 years ago was starting to gain popularities, and there were various devices which were developed, these kind of mini ultrafiltration machines, which were a variation on continuous renal replacement therapy equipment, could be delivered in an ICU setting or a step-down unit setting, and were kind of orchestrated just simply to perform slow, continuous ultrafiltration. So 3 randomized trials have been done to look at the outcomes from these various from these operations in various clinical settings, and the results have shown fundamentally, if you coalesce them around the probably the best trial with the which was the CRS study, which was published in 2012 and included 188 patients who had acute heart failure and worsening renal failure. And it was a trial of ultrafiltration randomized to continuous stepped dosing of diuretics together with augmented therapies. And the trial was discontinued early because there was actually worsening renal function in the ultrafiltration group. And so it was felt that this was not going to be superior to our standard of practice with diuretics. And since that period of time, the idea of isolated ultrafiltration for patients suffering from cardio-renal syndrome has kind of fallen by the way, although certainly under certain circumstances, when you have a patient who is clearly diuretic resistant and heading in the wrong direction and in pulmonary edema, we will be called upon to deliver dialysis or CVVH, whatever the circumstances may be, to regulate volume. These studies were focusing on patients who were prior to that sort of end-stage part of their natural history as an option other than diuresis. There's certainly, ultrafiltration is not an option to diuresis. Diuretic is used obviously first as your treatment of choice in those circumstances. And again, this highlights information from the CRS study. What about other non-diuretic therapies that we as nephrologists need to be aware of? Certainly, inotropes are important. Now, the importance of inotropes are that they are effective if the patient is in trouble, if they are suffering from low cardiac output or they're in cardiogenic shock. But using inotropes simply to improve cardiac function in a patient with acute kidney injury, and the cardiac function is not at the level of demonstrated low cardiac output or hypertension, inotropes don't have a role in that setting. The role is when the heart is actually in trouble. Vasodilators have been shown to improve hemodynamics, but in all the studies that have been published on the use of vasodilators preemptively to prevent acute kidney injury and heart failure, the renal effects have been demonstrated to be neutral. So again, if there is a cardiac indication to use them, do so, but the renal effects are not there. We have there's a new agent, an adenosine A1 receptor antagonist, which has been touted as potentially helpful in patients who have cardiac failure complicated by acute kidney injury. These agents act on the afferent arteriole to prevent afferent arteriolar vasoconstriction and dilate up the afferent arteriole. But again, the renal effects were similar to placebo in the studies that were published. We know about vasopressin antagonists, and particularly in a subgroup of patients who have problems with sodium metabolism and hyponatremia, and their effects, again, when looked at compared to standard of care, have not been able to demonstrate significance to the extent that we can routinely recommend these agents. Renal dose dopamine can certainly improve urine output, and does so by enhancing renal blood flow. Again, this is an agent which has been looked at in multiple studies, and in those studies it was unable to prevent progression to renal replacement therapy or the renal endpoints that it was seeking to improve. Again, in certain isolated cases, one may consider it, but you have to bear in mind that dopamine in and of itself has arrhythmogenic effects, increased incidences of atrial fibrillation being an example, and so it's certainly not a standard of practice in my experience. The big group of drugs that we obviously are all very familiar with, the ACE inhibitors, and these certainly have had proven benefit in treating stable heart failure patients in multiple studies. However, in patients presenting in the acute care setting with cardiac failure exacerbation and acute kidney injury, ACE inhibitors may in fact exacerbate the acute kidney injury on a hemodynamic basis. And so what should we do under those circumstances? If you withdraw the ACE inhibitor, there is the small risk that you will have an impact on blood pressure and potentially left ventricular function in patients who have reduced ejection fraction. But I think most of us have gotten in the habit of withdrawing ACE inhibitors in patients who have worsening AKI while we try to reestablish control of their volume status, and then potentially reintroducing them once the patient is back in more of a chronic stable situation. And that's the way I approach patients in the acute care setting. What about the approach? What about the response to cardiac resynchronization therapy in patients with heart failure? This is one area where there has been demonstrated some benefit in terms of kidney outcomes. And if you look at the two groups of patients here, the first, this is a group which looks at improvement in GFR before and after cardiac resynchronization therapy, before here, after here. The black bars represent controls, the white bars represent the patients who received CRT. And as you can see, there was an improvement in GFR and a reduction in BUN in these patients. And so this is one area where we have established some benefit, and certainly in those patients with severe enough cardiac disease to be candidates for CRT therapy, the hope is that there will be a beneficial impact on their renal function. Post-acute care is also important in this patient population, and probably as important as any of the therapies that I have already discussed with you. Diet and fluid management. This is the Achilles heel of many of our patients. They ignore their low-salt diet instructions. They tend to ignore fluid restriction. And in fact, fluid restriction is very difficult when you live in chronic heart failure, because chronic heart failure is a high angiotensin II state, and angiotensin II, as you know, is a potent dipsogen. But nevertheless, we should try to hold folks to a tight fluid restriction, because prevention is obviously very important under these circumstances. I'll show you some data on home telemetry services. These are services where visiting nurses go to the house. There's daily weights which are transmitted to local physician offices, and theoretically this should result in better compliance with medications and hopefully preventing patients being hospitalized, but in fact turns out not to be absolutely the case. Medication compliance is obviously a key factor. and patient education is certainly a key factor, as folks should understand their disease in order to comply with their medications and follow through on their dietary restrictions. So back in 2003, a study was reported in which 280 patients with advanced stage heart failure were placed on a home telemetry monitoring system which evaluated blood pressure, pulse, and daily weight, and then transmitted the information to physician offices, which led to changes in therapy based on how the patient was doing. And this had led to unexpectedly low mortality rates in this group, although there were no differences in hospitalization rates, which is actually surprising, and that was the primary endpoint. Subsequently, there have been multiple studies looking at various iterations of equipment that goes into the home with high levels of sophistication and telemetry, but again, disappointing results in terms of improving outcomes in terms of relapses resulting in heart failure or other morbidity impacts. So again, good clinical care, patient education, and then following patients closely and continuously within the hospital environment and deciding on a diuretic modality which is going to work, and reviewing that process as you go through is probably as good as any of what I have described to you today. So what did we do with our patient who was admitted? As you remember, the salient features were he was in congestive cardiac failure. He had a history of both chronic heart disease and chronic kidney disease with an acute exacerbation of both, which made him a mixture of type 1 and type 2 cardiorenal syndrome. And we had the options to either ultrafilter him, and you could argue to do that. He had ultrafilter / dialyze him because he had a BUN of 150, he had mental status change, he had a low serum sodium, which would have complicated his diuresis, and he had that very high BUN to creatinine ratio. He was also a morbidly obese man. Placement of a dialysis line was felt to be difficult, so we had decided to try conservative therapy first, and we put him on a Lasix drip and oral metolazone. And interestingly, he responded, well, not interestingly, but appropriately, he responded really well, because we addressed what was the physiological problem with him, which was congestion. He had high right-sided pressures. He certainly had probably high intrarenal pressures. And as we were able to diurese him, he woke up. His BUN and creatinine improved. And I saw him in the office recently, and he runs chronically a BUN in the 60 to 70 range and a creatinine of about 1.8 on a good day. And fortunately, this time we have him on a stable diuretic regimen, and he's a convert in terms of taking care of himself and has been watching his diet and his fluid intake. So far, so good at this stage. So summary of our approach. So cardiorenal syndrome is common in patients with acute decompensated heart failure and is associated with poor outcome. The pathophysiology of cardiorenal syndrome is heterogeneous and complex, and it involves multiple mechanisms. Prerenal hypoperfusion secondary to reduced cardiac output cannot explain many cases of worsening heart failure and renal failure, and venous congestion is a significant part of many of those cases. Much of the therapy that we do is not evidence-based and remains a clinical challenge, and therapeutic decisions often reflect a compromise between the potential benefits and harms and what we can do. And I think that summarizes my approach clinically. So let's move on and talk about hepatorenal syndromes and acute kidney injury and cirrhosis. And we'll, again, start off with a case discussion, and I'll run through the case first, and then we'll present the body of the talk, and I'll show you the outcomes of the case at the end. So we have a 57-year-old woman with NASH cirrhosis who was evaluated for worsening ascites and renal function. Previous history of diabetes, hepatic encephalopathy, improved with lactulose, a MELD score of 13. She'd been receiving serial paracentesis for ascites for the past 3 months and was now requiring approximately 6 liters of fluid removed every 2 weeks. Our advice was that we would do fluid and salt restriction and increase her diuretics, but in that context, her creatinine rose from 1 to 1.8 with the higher doses of Lasix and Aldacta that we prescribed. So at this stage, we were concerned about her developing hepatorenal syndrome, and so we called the hepatology group and renal consult from the in-service was called, and they thought that we were doing the right thing, but they wanted us to make the next medical decision, and you folks can help me to decide what that next medical decision is. And that is, what would be your next step in treatment? Continue doing what we're doing and give albumin infusions as needed. We should hold diuretics at this stage and start on midodrine and octreotide. We should refer her for TIPS placement. I'll highlight that for you in a moment. We'll refer her for urgent liver transplantation evaluation, and we'll take a fifth thing and suggest she moves to Florida and have a shot at getting a liver in Florida because the wait list is shorter. So let's press on, and hopefully we'll be able to make a sane and savvy decision at the end in terms of her clinical care. So we're going to talk about the background and epidemiology of Hepato-Renal Syndrome, some of the pathophysiology again. There have been diagnostic criteria which have been updated in 2015, a little bit about treatment and prognosis, and then we'll talk about the transdragular intrahepatic placement of stent and portal hypertension. So acute kidney injury is common in patients who have cirrhosis, and there are multiple causes: infection such as SBP, spontaneous bacterial peritonitis. Patients have GI bleeding and volume depletion in the context of paracentesis. Primary glomerulonephritis can occur in the context of hepatitis and cryoglobulinemia. Alcoholic hepatitis may play a role. They may receive the wrong medications, or they may develop abdominal compartment syndrome. And in fact, in terms of that relatively broad differential diagnosis, if you look at all patients who develop AKI in the context of cirrhosis, it's about 20% of patients who have hepatorenal syndrome, and 80% will have another diagnostic reason for their AKI. Either way, AKI in the setting of cirrhosis carries a very high mortality, and certainly untreated cases as high as 90%, and even treated cases as high as 60%. So what is the pathophysiology in this generation of Hepato-Renal Syndrome and Ascites? And there's this key paradox in that you have systemic vasoconstriction, which is mediated via renin, aldosterone, and catecholamines, and splanchnic vasodilatation, which is nitric oxide induced and possibly associated with cytokines or potentially bacterial translocation in the gut. There's also a low effective circulating volume, which generates sodium and water retention, but the sodium and water end up in the wrong place. It ends up in the acidic compartment or as edema. And the net result is that there is compromised circulation to the kidney and acute kidney injury in this setting. This is also a high cardiac output state, and so clearly you have high cardiac output but renal hypoperfusion, and this essentially represents a failure of the circulatory system to appropriately for appropriate homeostatic mechanisms, and the liver is central to all of this and the splanchnic circulation. So what do things look like if we look at the physiology? And here we spoke about Swan-Ganz catheter and central monitoring in cardio-renal patients. And I'm certainly not advocating that we use this in liver patients, but this was a clinical study which looked at some pre and post numbers and came up with some interesting findings. And these were patients who had ascites but normal renal function, who then subsequently progressed to developing hepatorenal syndrome and had central monitoring done initially and then subsequently. And we see that some of the changes here that are important, there is certainly some fall off in mean arterial pressure. The cardiac output pre-hepatorenal syndrome certainly is average. In hepatorenal syndrome, running at about 5.4. Renin goes up, LDO levels go up, norepinephrine goes up. This is what drives the peripheral vasoconstriction. Obviously, renal function worsens under this circumstance. Serum sodium falls as there's ADH secretion and water retention, and urine sodium is very low. So this is the physiology, and most of us know this, and the difficult part about it is how do we take care of it? How do we return the physiology back closer to normal? So hepatorenal syndrome has historically been thought to be a functional acute kidney injury due to hemodynamic alterations without parenchymal injury. And the pathophysiology is not fully understood, but it obviously stems from cirrhosis and portal hypertension, which are the key aspects. So it's a diagnosis of exclusion. There are no specific tests which we can use. We have to rely on our clinical acumen. There are overlap with other types of AKI, as we mentioned. And the 2015 criteria update and acknowledge this, specifically on how complicated these patients are. And so there's a group called the Ascites Club, which is an international group which looks at liver disease and Hepato-Renal syndromes and has defined some of the characteristics that we need to focus our attention on. In 2007, the criteria for Hepato-Renal syndrome was cirrhosis and ascites, creatinine greater than 1.5 for type 1 Hepato-Renal syndrome and greater than 2.5 for type 1 Hepato-Renal syndrome, and absence of current treatment with nephrotoxic drugs, absence of shock, and absence of finding of parenchymal disease such as proteinuria, greater than 50 red blood cells per high-powered field, and abnormal kidney function. And if you fulfill those criteria, you were deemed to have Hepato-Renal syndrome. This has changed in 2015, and basically now we have a diagnosis of cirrhosis and ascites, a diagnosis of acute kidney injury based on the AKIN stages 1, 2, and 3, which relate to the rate of rise of serum creatinine. No response after 2 consecutive days of diuretic withdrawal and plasma volume expansion with albumin at a dose of 1 gram per kilogram body weight. The absence of shock, no current or recent use of nephrotoxic agents, no macroscopic signs of structural renal injury such as proteinuria, microhematuria, or renal ultrasound changes such as hydronephrosis. And patients who fulfill these criteria may still have structural damage such as tubular injury. And ultimately, the hope is that urine biomarkers will be able to get us out of a bind to some degree in helping to differentiate these diagnoses. But at this point, if these criteria are filled, you are within your rights as a clinician to make a diagnosis of Hepato-Renal syndrome. The 2015 Ascites Club criteria for Hepato-Renal syndrome basically has staged Hepato-Renal syndrome differently to previously, which was Hepato-Renal type 1, which was sort of the more aggressive acute type, and type 2, the more indolent type of Hepato-Renal syndrome. We now look at 3 stages, and that's based on the rate of rate of serum creatinine rise versus baseline. You guys will be familiar with this from your talks on acute kidney injury, and that again, BUN is not obviously a good marker in Hepato-Renal syndrome due to this disturbance of nitrogen metabolism, and the biomarker issue again is alluded to, but not quite there in terms of being definitive. And so fundamentally, stage 1 in the 2015 Ascites Club criteria replaces what was previously type 2 Hepato-Renal syndrome, the less acute type, and types 2 and 3 replace what was previously type 1 Hepato-Renal syndrome. And this helps us with a dynamic treatment approach, and I think this slide is visible hopefully from the back, but basically if you have stage 1 acute kidney injury, you need close monitoring, remove risk factors such as nephrotoxic drugs, vasodilators, NSAIDs, decrease or withdraw diuretics, treat any underlying infection, and then try plasma volume expansion in cases where the patients are deemed to be intravascularly hypovolemic. And 1 of 3 things will happen. The patient will either resolve, they'll stabilize, or progress. If they resolve, you'll obviously do close follow-up. If they stabilize, you may continue further treatment for AKI on a case-by-case basis. And if they progress and move along to stages 2 and 3 AKI, then your care needs to be more aggressive in terms of withdrawal of diuretics, albumin expansion at this time by giving a gram per kilogram for 2 days, up to 100 grams of albumin per day, and then between 25 and 50 grams a day for up to 14 days afterwards. Assuming the patients respond, you'd go to the follow-up phase, but if they don't respond and they meet criteria for HRS, then one needs to consider vasoconstrictors and albumin, and we'll talk a little bit more about that in a minute. In the interest of time, I'm actually going to skip this slide. I'm just going to allude to you to specific forms of AKI which sometimes come up. This type of urine sediment we'll see and relates to bilirubin pigment nephropathy, and these are AKI patients with very high bilirubin levels, and it behaves in a way similar to myoglobinuria and rhabdomyolysis, and may be a confounding factor in some of our hepatorenal AKI patients. And then abdominal compartment syndrome is a somewhat overlooked entity, or has been a somewhat overlooked entity, but has become more important in terms of our diagnostic radar. One can measure a bladder pressure, and then it's viewed as a spectrum in terms of the abdominal compartment pressures here, resulting in impacting on renal vein pressures, very similar to the situation that I described to you in the Cardiorenal Syndrome, where you have congestion impacting on the kidney and impeding processes at a glomerular and tubular level. Same story here. Obviously, the culprit in liver patients is going to be tense ascites, and this may be a guide in terms of your approach to patients with tense ascites as to minimize one of the issues which may be further compounding AKI in this setting. So just to re-summarize on the diagnosis, so it's a diagnosis of exclusion. We've done the 2015 updates, and there may be more than one process. What about the treatment? So the treatment is supportive care, sobriety, address bleeding, treat with antibiotics, and try the new antiretrovirals in terms of the HCV treatments. Volume expansion with albumin is important, and we've listing the doses for you here, and I've mentioned those previously. And then liver transplant for those who are candidates, and as many of our patients are alcoholics, that is a problem because patients require 6 months of sobriety prior to a liver transplant, and they often don't have it. That said, treating alcoholic hepatitis, you can sometimes reverse the severity of liver failure, which will then favorably impact on kidney function. The vasoconstrictors that we have available, which act specifically on the splanchnic vascular system, include midodrine and octreotide. Octreotide is a somatostatin analog and has particular aspects of its care which are favorable in terms of splanchnic vasoconstriction. Midodrine acts peripherally to improve perfusion to organs which are impacted by vasoconstriction. The big drug that is used in Europe but is currently not available in the United States is terlipressin. Terlipressin is a vasopressin analog. It has effects both on the splanchnic vascular system and the peripheral vascular system. It's given as an IV infusion on a 4 to 6 hourly basis. It's widely used in Europe as first-line therapy for patients who present with hepatorenal syndrome, AKI, particularly hepatorenal type 1. The trial that was done in the United States looking at these patients, many of whom ended up in an ICU setting and were on norepinephrine, which can have many of the same effects as terlipressin in terms of augmenting blood pressure, didn't show a statistically significant benefit, terlipressin group versus standard of care treatment group, and therefore the drug still waits FDA approval in this country. I'll skip this because it's pretty self-explanatory, because I want to make an important point, and that is whatever treatment you choose, it has to be goal-directed, and the goal is to increase mean arterial pressure by 10 millimeters of mercury. And one of the issues is we shouldn't accept chronic hypotension in liver patients as de facto, particularly on treatment. And if pressure remains low, it is important to up-titrate treatment. And if a patient is on the floor on octreotide and midodrine and pressure has not bumped with therapy and their renal function is worsening, that patient needs to be escalated to the ICU setting so that they can be converted to norepinephrine, and their pressure then hopefully will come up under those circumstances and a better outcome can be expected. This gives you some guidelines just in terms of what we've spoken about on the blood pressure side. Skipping over to renal replacement therapy in hepatorenal syndrome patients. Many of these patients are very, very ill. renal replacement therapy is certainly an option if it's as a bridge to somebody who is waiting for a transplant. But if a patient is not a transplant candidate with end-stage liver disease complicated by Hepato-Renal Syndrome, sometimes a difficult discussion needs to be had as to the appropriateness of delivering renal replacement therapy in that setting. Again, this has to be evaluated on a case-by-case basis, but ultimately, folks do not benefit from renal replacement therapy unless a liver transplant is in their future. So that's a treatment summary of what we've discussed. What about this concept of transjugular intrahepatic stent placement? Here what we are effectively doing is we are placing a conduit between the portal system and the systemic system, portosystemic shunt of sorts. The risk is that we're obviously shunting blood that's very high in ammonia into the systemic system, so encephalopathy may be a complication, but this clearly decompresses the portal system and lowers portal pressure, so it's very potentially physiologically beneficial in terms of reducing risk of ascites and certainly GI bleeding, but does it play a role in helping with kidney disease, acute kidney injury and Hepato-Renal Syndrome by augmenting renal blood flow? And here's a picture radiographically of a stent in place, which is demonstrated diagrammatically on the left. So does TIPS work? There have been 5 trials in terms of randomized trials in terms of ascites, and there's 1 phase 2 trial in terms of Hepato-Renal Syndrome studies. The results are somewhat equivocal at this stage, but certainly in selected patients, there is the potential that TIPS may help Hepato-Renal Syndrome. And so we looked at our patient population at Mass General Hospital, and I illustrate here a small group of patients that have been reviewed looking at 90 days pre-TIPS time of procedure and then 90 days past in terms of glomerular filtration improvement, and we have been able to demonstrate some statistical improvement in GFR in a small patient population. At this point, however, there's insufficient evidence to recommend this for all patients. We do not have enough randomized control data, but the potential, as I mentioned, does exist to correct physiology. So in our 57-year-old woman with NASH, cirrhosis, refractory ascites, and Hepato-Renal Syndrome, what did we do? Of course, we did that, and we got this. And it was impressive, and again, this is one case, and it's anecdotal evidence, but this is over a period of sequential days, and this is looking at a serum creatinine, and that shows that a serum creatinine came down from a peak of 1.8 down to her baseline of 0.6. Her serum sodium improved because her circulation was enhanced, and we were able to get her off lactulose at the time that this went to press. But certainly we'll need to keep a close eye on that because ammonia levels can creep up over time. So summary, Hepato-Renal Syndrome is common. There's significant morbidity. Diagnosis is a challenge, and the 2015 Ascites Club criteria are what we should be using. The treatment is albumin replacement and vasoconstrictors titrated to MAP goals. Renal replacement therapy in selected cases as needed can be used. Ultimately, obviously, liver transplant is the endpoint, and TIPS may have a role in selected cases.